When performing arthroscopy for OCD of the elbow, it is recommended to use a relatively caudal camera portal. The reason for this recommendation is that with a relatively cranial camera portal, the lesion will often be directly above the tip of the arthroscope, making it difficult to view the caudomedial aspect of the lesion. Arthroscopy for elbow OCD is started with a thorough exploration of the joint. It is particularly important to examine the medial coronoid process for SCP or osteoarthritic lesions. The most common location for OCD is on the medial distalmost aspect of the humeral condyle. In most cases, the cartilage flap will be in place, although partially torn from the humeral bed. The lesion in the elbow is recognizable by the irregular, undulating cartilage of the flap. The joint is routinely instrumented, and a right-angle probe or curette is inserted first to determine the status of the flap. A small joint grasper is then inserted and the flap grasped at an edge where it remains attached to normal cartilage. The grasper is gently rolled away from the normal cartilage to try and tear the flap away, leaving as little diseased cartilage as possible. The graspers are worked around the edge of the lesion until it is released. If the flap is large, it may be rolled around the graspers in order to remove it from the joint. If large flaps of diseased cartilage remain, they should be removed with the graspers. A small curette is then inserted to check the edges for loose cartilage and to curette the sides of the bed to right angles with the joint surface. The curette may also be used to gently scrape away loose subchondral bone in the bed. The bed of OCD lesions is usually soft and vascular, unlike the subchondral bone of osteoarthritis. Therefore, it is usually not necessary to perform microfracture or aggressive abrasion. Shut off the fluids to look for adequate subchondral bone bleeding. Be certain that there is adequate outflow to allow decrease of pressure within the joint.